Alright guys, this pressure volume loop may seem intense at first, but we're going to dominate it. It basically just plots left ventricular volume on the x-axis and left ventricular pressure on the y-axis. So let's just go ahead and start here where the mitral valve opens, at the bottom left of the diagram. And so at this point in the diagram, on the x-axis, you see the end systolic volume. This indicates that we have some volume remaining in the chamber after we've completed systolic ejection. So we need to replace the ejected volume. What happens? We open the mitral valve. So the 4 and 5 here, these indicate the rapid and the slow filling period in diastole. There's an arrow pointing to an area just after the mitral valve opening, indicating that we could potentially hear an S3 here. So let's play that real quick. Okay, here we go. Alright, you guys hear that? It's rather quick, but S3 is kind of a confusing heart sound because it can occur in a normal person and it can also indicate an underlying pathology such as a dilated ventricle. Now the best theory so far is why an S3 occurs is that when the ventricular wall hits a limit of expansion from the rapid filling period in diastole, it makes this noise. Now as we continue to travel along this way with the black arrow, we see another arrow pointing to S4. Now we said that S3 could occur in the early rapid diastolic filling period. So when do you think this S4 can be heard? It occurs in the late or reduced diastolic filling period. And S4 occurs when the left atrium squeezes down to push that last bit of blood into a non-compliant left ventricle. So the incoming blood creates a very turbulent flow because the ventricle is not going to expand. And the turbulent flow of blood creates an audible sound that you can hear over the apex. What does it sound like? Well, let's listen. Alright guys, let's keep going. Next up, when we finally reach the corner, we hit S1. We also have an arrow labeling mitral valve closure. This makes sense because the closure of the mitral and tricuspid valve makes the S1 heart sound at the end of the diastolic filling period and at the onset of systole. So let's keep on going. Next, we start moving vertically in this direction. This is because there's a change in pressure but no change in volume, because both the aortic and the mitral valves are closed. So this phase 1 here represents left ventricular contraction against a closed mitral and closed aortic valve. We call this isovolumetric contraction because iso means same. There is no change in volume. That's because the back door, the mitral valve, and the front door, the aortic valve, are closed. But when pressure rises to a high enough point, the aortic valve is going to swing open. And we start moving to the left on the diagram because we're decreasing left ventricular volume because volume is going into the aorta. So the ventricle is going to contract and increase pressure all the way up until ventricular relaxation occurs. This is where the curve peaks and kind of starts to drop off. When the ventricle relaxes enough, the pressure in the aorta will now be greater than in the ventricle. What's going to happen? Well, now we get closure of the aortic valve, and this is part of our dub or S2 heart sound. The last step we have is the opposite of isovolumetric contraction. This is isovolumetric relaxation, and this is represented here on number 3 of your diagram. So this ventricular relaxation occurs with the aortic and mitral valve closed. Eventually, we're going to have enough relaxation where the left ventricular pressure is going to fall below that of the left atrial pressure. And what's going to happen again? Well, we start the whole thing over with the mitral valve opening. What are the other loops on this diagram about? Well, the lime green curve represents an increase in preload. The loop expands more to the right because the end diastolic volume is greater in the left ventricle. Notice how we're shifting on the x-axis. Preload and end diastolic volume are the same thing. So an increase in end diastolic volume will stretch the sarcomeres. And by Starling's law, this will cause an increase in the stroke volume, but it will not change the end systolic volume. Notice how it's in the same place on this side because all we did was increase more blood into the chamber. We haven't changed the ability of the chamber to contract. We've just increased the ability to rebound for how much volume we put in there. Now this red-orange curve here represents an increase in contractility. Remember that contractility is the intrinsic ability of the muscle to compress the blood in the left ventricle. So the closure of the aortic valve occurs at a lower end systolic volume. Notice how we have shifted out here. This is because the ventricle is better at ejecting blood due to increased contractility. Now, what about the last situation in which we have an increase in the afterload? We would see this situation in something like hypertension. The increased aortic pressure will require your left ventricle to contract harder to reach the pressure necessary all the way up here to swing open the aortic valve. Notice how the Y value is much higher compared to the other ones. We have to reach a higher ventricular pressure before we can open the aortic valve. So if you have to push much harder to eject volume from the left ventricle, guess what's going to happen to your stroke volume? Well, it's going to drop. It's going to get smaller, right? Notice how this is also representative on our diagram. This is our stroke volume here. It is decreased. So our stroke volume drops. This means that more blood remains in the ventricle at the end of systole. This is represented by the shift on the x-axis of our diagram. Alright guys, I'm sorry, but I feel like there's another diagram coming up. The next diagram shows us how you're expected to integrate the information about what's going on in the atria, the ventricles, the jugular vein, in addition to heart sounds and the electrocardiogram. You'll be expected to put all this information together when you're evaluating a real patient and when you're trying to answer questions on your Step 1 exam. So we're going to roll through this diagram starting with atrial systole here. Even if this diagram didn't say atrial systole at the top, we can see that the atrial pressure reading shows a slight increase in atrial pressure. This makes sense because the atria are contracting and compressing the blood, aka systole, to push the blood into the respective ventricle, either the right or the left. Now the depolarization necessary to make the atria contract is shown here as our P wave. Now how does this correlate to the A wave that we see on our jugular venous tracing? Remember that there is no valve in between the right atrium, the superior vena cava, and the jugular veins on the right side of the heart. So any changes in pressure of the right atrium are going to be reflected all the way back up to the jugular vein. So anytime that your atrium are contracting and depolarizing, there will be a buildup of pressure that's transmitted all the way back into the superior vena cava and the jugular vein. So we can see this, and it's represented as our A wave, where there's a peak in the pressure of the jugular vein. I remember this by A means atrial. So if atrial contraction is pushing blood into a non-compliant ventricle, sometimes we could potentially hear an S4 heart sound during this phase. Okay, now let's go on to the next one. Let's take the next step and examine what's going on during isovolumetric contraction and rapid ejection. We know the QRS complex represents ventricular depolarization. When we depolarize, the result is ventricular contraction and therefore an increase in the left ventricular volume. Notice there's an increase in this pressure tracing. The increased pressure in the left ventricle will slam the mitral valve shut, and we get mitral valve closure at this point. This creates a component of the S1 heart sound, so we can hear some audible noises in this moment in time. The ventricle continues to contract until the pressure in the ventricle exceeds the aortic pressure, and then we have aortic valve opening. We can see that here. We can confirm this by noting that the ventricular volume is then going to drop right after we open that aortic valve. Now, what would we see in the JVP tracing at this point? Well, we would see this thing called a C wave. So what happens is that we're contracting our ventricles. So here's our right ventricle and here's our right atrium. We're going to push on the undersurface of the tricuspid valve. This is going to lead to an increase in pressure that is transmitted all the way back to the jugular vein. Eventually, we're going to open up the pulmonic valve, and then we're going to resume with the X descent, where the tricuspid valve drops back down into its original position. So the leaflets returning to normal position after they're pushed up into the right atrium slightly by bulging represents the X descent. Okay, now let's move on to the next step. Now we're going to examine reduced ejection and isovolumetric relaxation together. Eventually the ventricles start to reduce their contraction and start to relax. So the pressure in the aorta is going to exceed that of the left ventricle. Therefore, we get aortic valve closure at this point in time. Now, what is this little dicrotic notch that we're talking about here? Well, dicrotic, first of all, means 2 beats. So this little drop here, we'll draw it out, it looks like a V. This is the dicrotic notch. It is created from the regurgitation of a tiny bit of blood into the left ventricle as the aortic valve closes. The regurgitating blood actually pulls the aortic valve leaflets backwards towards the left ventricle. Then the leaflets recoil forward into the aorta as the coronary arteries are perfused. This creates a trough or nadir, and then it goes back up. This is the dicrotic notch. So this whole process creates the dicrotic notch. Not exactly the highest yield point, but it's important to understand everything. So now let's move on to the left atrial pressure tracing. What is this weird Harry Potter looking scar here? At this point in time, there's going to be an upslope, a downslope, and then a return back to normal. So this upslope represents that tiny bit of blood that gets regurgitated every time that the aortic valve is closing, and the downslope represents the elastic recoil of the aortic valve back into the aorta as the coronary arteries take blood in. We can detect the pressure changes in the left atrium because the mitral valve is closed and will move up and down into the left atrium when the changes in volume are occurring in the left ventricle. More importantly, S2 occurs during this time because it is a closure of the aortic valve and the pulmonic valve. Now what about the V wave in our jugular venous tracing? This corresponds to filling of the right atrium. The T wave represents ventricular repolarization. This tells us that the ventricles are repolarizing. It seems like it occurs early because it does. The electrical changes are one step ahead of the contractile forces that are changing the volume and pressure tracings. So now we have diastole noted as rapid and reduced ventricular filling on your diagram. You can see here that the left atrial and left ventricular pressure tracing are stacked on top of each other, the dotted line and the solid line. There is no mitral valve. It's open, right? There's nothing separating the left atrial pressure from the left ventricular pressure. They are the same. Now, can you remember why we have an S3 during this point in time? Blood is rushing into the left ventricle, and the ventricle is going to hit a limit of expansion. This can occur in young people that exercise a lot, and it can also occur in pregnant people. So it's not always bad. But consider this population if it's in the vignette, if you're being asked a question about the S3 heart sound. So the last thing that we need to consider is the Y slope of the JVP. Now, what does this represent? Well, both the atrioventricular valves are wide open. Blood is draining from the jugular veins into the superior vena cava, directly into the right atrium, and directly into the right ventricle. So less blood drops the pressure, right? Notice there's a descent. Flash quiz time, guys. Let's knock this out. So how does beta-1 blockade affect contractility and stroke volume? Beta-1 blockade leads to a decrease in contractility and stroke volume. We are pros at beta-1 stimulation of the heart. If you aren't that, then you will be by the time we finish this physiology section. Remember, beta-1 adrenergic receptors are associated with the G stimulatory subunit. This leads to an increase in adenylocyclase activity, which leads to an increase in cyclic AMP formation. This is a key step. This increase in cyclic AMP means that there will be a liberation of protein kinase A. Now, protein kinase A will go on to phosphorylate the L-type calcium channels, which means we're going to increase the influx of calcium, and we're also going to phosphorylate the inhibitory protein phospholamban. By slapping on a phosphate to that, we're going to decrease its ability to function. So this decreased phospholamban activity means that we have increased sarcoendoplasmic reticulum calcium ATPase activity, so we increase the amount of calcium that we can store in our plasmic reticulum for future contractions. This means future increase in contractility and stroke volume. So we're blocking this entire pathway with beta blockers. Therefore, we're going to counteract this and have a decreased contractility and decreased stroke volume.